Hi, you're listening to the Psychopharmacology Institute podcast. I'm your host, Dr. Wegdan Rashad, and this is a show that aims to help you, the mental health clinician, stay sharp on psychopharm. Today, our episode, following the previous episode, is about psychiatry and Parkinson's disease. Today, we will refresh our knowledge on how to manage depression, anxiety, and psychotic symptoms associated with Parkinson's disease. Our expert today is Dr. Greg Pontone, Director of the Parkinson's Disease Neuropsychiatric Clinic at Johns Hopkins University School of Medicine. All right, let's get started. When Parkinson's disease was first described by Dr. James Parkinson, he made a point to state that the, quote, the senses and intellects being uninjured, end quote, which is clearly untrue. They used to think that the cognitive impairment that often occurred was a result of people just getting old. But no, we have now established that the neuropsychiatric symptoms of Parkinson's are actually part of the disease process with unique features that we must keep in mind as clinicians. Fun fact, did you know that these neuropsychiatric symptoms such as mood disturbances happen in at least half of everyone affected by Parkinson's? And within 20 years of diagnosis, at least, and listen to this, 80% of individuals will have developed dementia. Big numbers right there. So let's try to understand why this happens and what we can do to manage these symptoms.
Because almost all psychiatric disorders are overrepresented in Parkinson's compared to the general population. There's more depression, more anxiety, more psychosis. So one contributor is that it's a reaction to the diagnosis. Having a sort of progressive, chronic, degenerative disease for which there is no cure alters your interpersonal roles, causes disability, and has other psychosocial consequences. And so that almost certainly contributes to the increased prevalence of psychiatric disorders. In addition, we think that there's an argument that the biology of Parkinson's disease, where the pathology occurs within the brain, is actually a direct cause in some cases of the increased prevalence of psychiatric disturbances. For instance, when you dysregulate the raphe nuclei, which produce serotonin, and the locus coeruleus, which produces norepinephrine early in the disease, we know that these are two neurochemicals that are vital to the regulation of mood and anxiety in general. And because you lose these transmitters to a certain extent in the disease process, it might in part explain the increased prevalence of these disorders. And finally, once the disease is recognized, once it's been diagnosed clinically, you start administering these dopaminergic medications to treat the motor symptoms, the movement symptoms of the disease. So ideally, we would like to target the dopamine treatments to the nigrostriatal pathway. But you're taking these medications orally, so they're flooding the brain and going to the mesolimbic and tuboinfundibular tracts and overloading those non-deficient areas with dopamine. And so it's possible that the consequence of this excess exogenous dopamine in the wrong places is part of what contributes to psychiatric disturbances.
So in summary, the reaction to Parkinson's disease diagnosis could explain why depression and anxiety are higher in these patients, especially at the onset of diagnosis. Also, biologically speaking, disturbance to brain structures due to the disease process can also count. And finally, you must consider dopaminergic medications as contributing factors too. After the break, we will dig deeper into managing depression associated with Parkinson's.
The prevalence rates of depressive disorders and Parkinson's are higher than that in the general population and even other similarly disabling diseases, with prevalence rates from about 25% for major depression up to 50% if you include both major and minor depressive disturbances like dysthymia. An association between the symptom severity, so having maybe worse tremor or worse rigidity, and depression, being older and having a longer duration of Parkinson's predict a failure of depressive episodes to remit. So these are things that can influence the episodic nature of the depressive disturbance within Parkinson's disease.
Okay, so up to half of your Parkinson's disease patients will develop depressive disturbances. And that is why it is so important to screen and ask about them. So how do we actually treat it though? Can we still use our bread and butter MDD algorithms?
Now, the treatment of major depression and Parkinson's has been studied over the years. And basically, the take home here is that almost all of the standard treatments in the general population for depression are reasonable to try in Parkinson's. That includes ECT, RTMS, cognitive behavioral therapy, all the classes of antidepressants, SSRIs, SNRIs, tricyclics. However, with tricyclics, you just have to be a little careful because if they have anticholinergic side effects, the people with Parkinson's are a little more likely to have both the confusional effects from the anticholinergic side effects, but also increase their risk of falls. The clear signal for efficacy is with the selective serotonin reuptake inhibitors in cognitive behavioral therapy. They both significantly improve depression in Parkinson's. Now, those have best evidence. However, there is also good evidence for SNRIs like Effexor in individual studies. So in terms of having a first-line treatment, the selective serotonin reuptake inhibitors and cognitive behavioral therapy should be chosen first because they also have a low side effect profile.
Aha. So generally, the treatments for depression we use can be applied to our Parkinson's patients, with some evidence pointing towards SSRIs and CBT. And of course, we avoid TCAs and other agents that have anticholinergic action. Okay, this sounds straightforward, but I hear you, dear psych nerd, asking the question, what about drug interactions between antidepressants and dopamine replacement therapies that my patient is taking? We got you covered.
And when you use antidepressants, there's a concern that they might interact with certain dopamine replacement therapies. Specifically, we often use things like rasagiline and selegiline to treat Parkinson's disease. And these are MAO-B selective inhibitors, so monoamine oxidase B selective inhibitors, meaning they're reversible. And even though there's a theoretical warning of using these together, there's big clinical trials in Parkinson's that show that they're used concurrently in Parkinson's without increasing the overall adverse effects. You should absolutely still exercise caution, but I will tell you that in clinical practice in Parkinson's, antidepressants are used in combination with these monoamine oxidase B selective inhibitors. Interestingly, although it's thought to be an antidepressant that probably has some pro-dopaminergic properties, there's no evidence to suggest that bupropion has any additional benefit for depression and Parkinson's over the other antidepressant classes. Also, there's no evidence to say it's any less efficacious. So I would say that it's also a very reasonable choice to treat depression.
Nice. So antidepressants plus selective MAO-B inhibitors can be used in clinical practice. However, just practice some caution. Also, bupropion can be considered. Just watch out for the seizure risk, as we do with bupropion in general, right? Next up, we talk about anxiety.
So looking at anxiety as a standalone symptom, up to 55% of persons suffering from Parkinson's have clinically significant anxiety symptoms. That means severe enough to impact their daily life. According to a recent meta-analysis and systematic review, at least 30% have a diagnosable, diagnostic statistical manual diagnosable anxiety disorder. Now, in Parkinson's disease by disorder, generalized anxiety disorders are probably the most common. In fact, more common than episodic. But things like panic disorder and panic-like attacks are still increased over the prevalence that you see in the general population.
So again, anxiety is a real issue. And interestingly, GAD is more common overall than episodic anxiety. I did not know that. Generalized anxiety is often more challenging to pick up unless you directly ask about it, because it may be overlooked by patients as just worrying. So let's keep our eyes open for that. Now, is treating anxiety going to be the same as for the general population?
So there is a little bit more of a difficulty in treating anxiety in Parkinson's for many reasons. One is it may not follow the same mechanistic causes that anxiety in the general population does. And so this example of on-off fluctuation associated anxiety is probably more anxiety due to a dopaminergic cause, which you wouldn't necessarily see in the general population. And the other problem is there really have not been any randomized controlled trials of pharmacologic treatments in anxiety for Parkinson's. Now, there are at least 2 on their way, one that I'm conducting myself and one being conducted at the University of Rochester here in the United States for BOOSPAR. But right now, best evidence, and there are some clinical trials supporting this for treating anxiety in Parkinson's, is cognitive behavioral therapy. Otherwise, there's insufficient evidence to support other treatments of anxiety currently.
So anxiety in this population might have a more dopaminergic cause, and so treatment with conventional agents may not be effective. The bottom line so far is to use CBT for anxiety. Check. We have covered depression and anxiety so far. Next, we will explore psychosis associated with Parkinson's disease. When studying Dr. Pontone's video lecture on this topic, by the way, the link to the full lecture is in the transcript, I came across a psych nugget saying that psychosis in Parkinson's tends to occur later in the illness. Now, that's not surprising, but I'm still curious as to exactly why it happens.
There's really 2 main reasons for this. One is the brain areas that we think are involved in psychosis and Parkinson's disease aren't affected until later pathological stages, maybe Braak stages 4, 5, and 6. And so that takes time and usually occurs in more advanced disease. The second reason is that dopamine replacement therapies are typically involved or associated with psychosis and Parkinson's. Now, there isn't a linear association, meaning that there's a dose-response relationship between psychosis and the dopamine, but clearly the absence versus presence has a different effect. So I'll give you an example. In untreated Parkinson's, psychosis occurs in about 10% of patients. Once you introduce dopaminergic treatments, that prevalence goes up to somewhere between 40 and 60% of patients if you look at the entire course of the disease.
And now we circle back to dopaminergic agents playing a role in the manifestation of neuropsych symptoms. By the way, Dr. Pontone mentioned the Braak staging. That's BRAAK. It is basically a staging system that classifies the degree of pathology in 6 stages, depending where Lewy bodies are found in the brain. Each stage correlates with clinical presentations. You can learn more by referring to the full lecture on our website.
Now, an interesting symptom that occurs fairly specifically in Parkinson's is what we call passage hallucinations. And that's seeing some sort of motion of an indefinite object out of the periphery of your visual field. And when you confront it in your frontal visual field, it's not there. And so patients will often say if it's low, it could have been a mouse scurrying by. If it's high, maybe it was a bird. But when they turn to look at it frontally, it's not there. There's something called a sense of presence hallucination. So the feeling or idea that someone's close by. So often patients will say, I'm standing in a room and I think someone's walked up right behind me. I turn around and look and no one's there. This has been reported in the general population, but nowhere near as commonly as in Parkinson's. Now, in Parkinson's disease, delusions are much less common than hallucinations, and they only occur probably in 5 to 10% of patients.
So to summarize, unique psychotic symptoms include passage and presence hallucinations. Also, hallucinations seem to be more common than delusions. Interesting. Dr. Pontone goes on to tell us more about how we can diagnose Parkinson's psychosis.
So there is a specific criteria, a diagnostic criteria for Parkinson's disease psychosis that's different than the criteria for schizophrenia or other psychotic disorders. And here's an example of the National Institutes of Neurological Disorders and Stroke criteria for Parkinson's disease psychosis. Basically, you must have one or more of the following symptoms, which is illusions, a false sense of presence, hallucinations, and delusions. And then these symptoms must occur after the onset of Parkinson's disease. If they occur before Parkinson's, again, that's not likely to be the cause. They have to be recurrent or continuous for at least a month. And this excludes things like toxic metabolic psychosis or psychosis due to other delirium-related events. And then finally exclude other causes like mood disorders with psychotic symptoms or schizophrenia, for instance.
So the NINS criteria says at least one symptom of illusions, delusions, hallucinations, or false sense of presence that happened after onset of Parkinson's and has been recurring for at least a month or continuous in course. Let's take a break and then jump into the last part of our podcast today, and that is the management of Parkinson's psychosis. All right, so a patient with a 10-year history of Parkinson's disease starts presenting with some psychotic symptoms. What do we do?
In the case of new onset psychosis and Parkinson's, it's very important to do a complete medical workup that includes blood work, physical examination, and in some cases, maybe even chest x-ray, head imaging, or other specific types of medical diagnostics. You would want to review the medications to see if there's anything that was either recently added or adjusted that could cause or contribute to the risk of psychosis and Parkinson's. So common things are opiate pain medications, anticholinergic bladder medications or sleep aids. So diphenhydramine, for instance, is very commonly used as a sleep aid and can increase the risk of psychosis. And any centrally acting medication. If Parkinson's medications had been recently increased or changed, that could be the cause of the new onset psychosis, and you'd want to review that with the treating neurologist.
So full workup and reviewing medication change. What's next?
And if you don't find any medical cause to explain the onset of psychosis, you might assume then that it's related to the overall disease process and the use of dopaminergic therapies and consider the use of an antipsychotic. There is some evidence that treatment with cholinesterase inhibitors might be helpful, but this is a lower level of evidence that primarily comes from secondary outcomes in cholinesterase trials for cognitive impairment. And then there are some non-pharmacologic techniques to address Parkinson's disease psychosis. So for instance, there are things like looking away from the visual hallucination and then looking back, keeping rooms better lit, avoiding isolation, and things like that.
So we can start with non-pharmacological techniques to help the patient and family cope with symptoms. We won't get into those too much in this episode, but we do have a full lecture on managing neuropsychiatric symptoms of neurocognitive disease in our library. Links are in the transcript. Question: how about antipsychotic use for Parkinson's psychosis?
When we talk about antipsychotic therapy in Parkinson's, the main risk is that antipsychotics work by blocking postsynaptic dopamine receptors. And if you do this in Parkinson's disease, you'll worsen the motor function. So essentially, you're working against the main treatments of Parkinson's. And so you have to choose antipsychotics that avoid this postsynaptic D2 dopamine type 2 receptor blockade. And really, there's only 3 that do this in an acceptable way for Parkinson's, and that's clozapine and quetiapine, which are available on the market in most countries, and then a new drug called pimavanserin. Now, all of these drugs have been shown to have efficacy to some extent in clinical trials, and basically, clozapine is clearly efficacious and has acceptable risk, but requires specialized monitoring. And this monitoring is primarily for the absolute neutrophil count because there's a risk of neutropenia and agranulocytosis, which can be a life-threatening side effect. Quetiapine, when you look at all of the trials, it lacks evidence of clear efficacy, but it doesn't require specialized monitoring. And if nothing else, it seems to sort of minimize the agitation and distress caused by the psychosis if it doesn't actually modify the actual psychosis. So it still is often used in practice despite this lack of efficacy. The newest drug is pimavanserin, which works through 5-HT2A inverse agonism. So it's a serotonergic mechanism. It's proven to be efficacious in the treatment of Parkinson's disease psychosis and doesn't impair motor function and is generally well tolerated. There is one caveat. It's mostly at this point been tested in non-demented Parkinson's disease psychosis. And so if you're using it in demented Parkinson's, there may be additional considerations. So just keep that in mind. But using any of the other antipsychotics, you risk worsening the Parkinson's disease. And use of almost any antipsychotic increases the risk of all-cause mortality in the elderly. And so you want to also know that you're accepting that risk by the time you choose to use these medications for psychosis and Parkinson's.
So first, clozapine. But remember to monitor for absolute neutrophil count. I'm going to add the dose here, which typically starts from 6.25 milligrams per day and can go up to 50 milligrams. So very low doses of clozapine. Another option is quetiapine. However, watch out for sedation in the elderly and, of course, the metabolic effects of it. Doses can start at 12.5 milligrams per day and titrated up to 150 milligrams. Then we have pimavanserin, which should be used in caution in patients with dementia. And of course, we should remember that there's a black box warning associated with antipsychotic use in these patients. And that's about it for today's podcast. I hope you got a good refresher and maybe even learned something new. In case you snoozed, here are the key points. Psychiatric symptoms can occur in Parkinson's disease as a reaction to the diagnosis and disability associated. Also, consider biological factors and dopaminergic medications too. For depression, evidence points towards SSRIs and CBT. Avoid TCAs. Antidepressants plus selective MAO-B inhibitors have been used clinically, but practice caution for drug interactions. For anxiety, consider CBT. Pharmacologically, anxiety might have a more dopaminergic mechanism in Parkinson's patients. Unique psychotic symptoms in Parkinson's disease include passage and presence hallucinations, and hallucinations seem to be more common than delusions. Clozapine, quetiapine, and pimavanserin can be used in psychosis with Parkinson's. Did you know that a lot of today's content was extracted from our CME presentation entitled The Psychopharmacology of Parkinson's Disease, Identifying and Treating Psychiatric Syndromes? Check it out on our website, visit piupdates.com, and become a premium member already. We have a bunch of CMEs and essay credits for you to collect. If you're a premium member or premium plus member, you can refer a friend to join our platform, and you will receive a $50 Amazon gift card. Boom. The following people participated in this episode: Dr. Flavio Guzman as a general editor, Andy Rode as the audio engineer, Pamela Gonzalez as the project manager, and myself, Dr. Wegdan Rashad, as the host. We'd also like to thank Dr. Greg Pontone for being with us. Thank you for joining us in today's podcast. Until the next episode, goodbye.